Good afternoon, everyone. Thank you for your patience. I got on the computer a little while ago and killed it, but thank goodness Tim got it back on, our tech from Northwest Telehealth. So, yeah, Tim's waving in the background. Thank you once again, everybody, for joining us for this month's monthly telehealth broadcast. And I don't have a lot, I guess, of announcements right now. Just thank you for everybody's support and everybody who comes each month and our new attendees. We're very happy to have you all today. We're excited for next month. Next month is Parkinson's Awareness Month. And so in the next week, please go to our calendar online and look for our newsletter going out. There is a whole bunch of things going on, a couple of restaurants, fundraisers, and some different things, maybe even a I Wear Parky shirt fundraiser that you can take part in. But I'm going to just go ahead and turn it over to, I did it. I almost did it. I was good. This is Dr. Emery, but his first name is Jeffrey, and I almost called him Dr. Jeffries again. But Dr. Emery is here to speak today, and I'm going to turn it over to you.
Okay. Thanks. Well, thank you everyone for coming out and taking time out of your busy day. Today's topic may be a little unusual for the Parkinson's support group, but I promise I'll tie in this whole discussion to Parkinson's. And there's, of course, a lot we don't know about Parkinson's, but there's a lot we do know about Parkinson's, and it's certainly a growing area of knowledge in the medical world. And so I want to tie in what it is that I spend most of my days doing, and how that can benefit patients with Parkinson's, and certainly benefit caregivers of those Parkinson's patients, and also family members. And hopefully some of what you hear today may be review, but hopefully there'll be a lot of new things that you'll hear today. And I strongly believe the information that I have to share with you has the ability to save lives of millions of Americans, hopefully yours or a family member or someone that you know or love. So I'm excited to share this with you today. I spend most of my time, my background is in family medicine. I spent 10 years practicing the full gamut of family practice. And then about 2 years ago, I received training in specialized training in what's called the Bale-Dunine method of cardiovascular prevention. And now I spend vast majority of my clinical efforts in the area of heart attack, stroke, diabetes, and dementia prevention. But interestingly, all those things also flow over into touch in the area of Parkinson's also. And so I'll tie all that together. So let's get started. I just want to cover some of the current statistics that we're dealing with in this country. Heart disease, as many of you may know, is the leading cause of death among both men and women. Over a third of, well, if you were to, they've done studies and polled women, and over a third of women don't realize that that's their number one cause of death. But it's both men and women, it's our number one cause of death. In fact, you can see there over 600,000 people die of heart disease every year. And that comes down to about 1 in every 4 deaths is as a result of cardiovascular disease. And it's pretty astounding when you look at the statistics. About every 20 seconds, so during this time that we spend together, there'll be a lot of people that have already died of heart disease. 1 in every 20 seconds, or every 20 seconds someone has a heart attack, and then every minute someone dies of a heart attack. And bottom line, what I hope you all take away from today's discussion is that heart attacks, by and large, are preventable if we're doing something different than we're currently doing right now in the current standard of care. But none of you and no one that you know or love should ever have to die of a heart attack. So let's turn and look at stroke. It's the leading cause of long-term disability. It's the fourth leading cause of death in the United States, and one person every 4 minutes dies of a stroke. Every minute, one and a half patients suffers a stroke. When you look at the statistics, 800,000 strokes a year occur in this country. And 1 in every 4 of those is a recurrent stroke. So a lot of times people, whether it's a heart attack or stroke, kind of have this false reassurance that they survived it, they're out of the woods, they don't have anything to worry about. And yet the process that got them there in the first place is still perpetuating. And you can see every year, 25% of people that have had a stroke before. And usually it's a progressive process where someone may have a mini stroke. Their risk of having a full-blown stroke within the next 6 to 9 months is very, very high. So it should always be a warning to us that we need to be very aggressive in managing these patients. And a lot of patients have multiple conditions going on that are contributing to these things. Again, stroke is by and large a preventable condition, not with what we're currently doing in the standard of care, but the information I present to you today will show you how, if being more aggressive, we can prevent strokes. Okay, so let's look at dementia. Interestingly, what we now know is that, again, we don't know everything about dementia. There's many different causes of dementia. Just to give you an overview, dementia is just kind of a term that refers to memory loss, so a non-specific. There's many different forms of dementia. Alzheimer's dementia is the one we all kind of associate with advancing age, senile dementia. But there's also vascular dementia, which is largely those people who are real prone to vascular disease, whether it's heart attack or stroke. That same process is insulting the brain over and over and over, and so they can develop what we refer to as vascular dementia. And there's a couple of other different types. But when we look at dementia, certainly we do see it more commonly with age. It's not that it's a normal process of aging. It's just that those processes, that disease processes, are piling up and confounding the older we get. And so we start to see 1 in 8 individuals over the age of 65 is diagnosable with some form of dementia, and that incidence climbs with every passing decade of life. And in fact, part of it's due to the baby boomers coming of age, but the incidence of dementia is expected to double by the year 2030, which is pretty astounding when we look at the impact on families and resources that it's going to take to care for all those patients. So it's pretty important that we do something now to stop that progression of this disease. It is the 6th leading cause of death. And causes 1 in 3 deaths in patients over the age of 85. So this is impacting a lot of people. I'm sure not many of you could raise your hands if I asked you to show your hands, those of you that know someone that has suffered a heart attack, stroke, or dementia. Most of us, it's affected our lives in one way or another. So diabetes and obesity, this is an epidemic in our country, and it contributes to all the things that we just reviewed: heart attack, stroke, dementia, and we'll see in the future may also have its contributing factor to Parkinson's disease as well. But certainly we can look around us in this country and see that obesity is impacting just about every family in this country. 1 in 3 Americans is, and I tie these two together because the statistics are so similar. 1 in 3 Americans is obese. About 10% of our country is diabetic. A third of those patients don't even know they're diabetic. And it's wreaking its havoc on their neurologic and vascular systems. But about another 20% of Americans, at least, and that's a pretty conservative figure. Some estimates say over 35% of our country is pre-diabetic. Pre-diabetic would be defined as abnormally elevated blood sugar levels that aren't yet high enough to be considered diabetes, and yet elevated blood sugars in that what we would refer to as a pre-diabetic range are still damaging to our systems. In fact, there have been papers that have certainly linked elevated blood sugars long before they're high enough to be diabetic with advancing dementia. Elevated blood sugars are damaging to the vascular system, they're damaging to the neurologic system, and are contributing to a lot of the disease we see in our country. And as you can see here with diabetes, particularly not obesity, but diabetes, prediabetes is the leading cause of nerve damage, kidney failure, and as a result of nerve damage and damage to the vascular system, lower limb amputation. So it's a scary statistic, and I wanted to review with you folks. These will kind of show you the advancing epidemic of obesity in our country starting back at 1990. I'll give away my age here. In 1990, I graduated high school. So, and I can remember back in that time, I had one overweight kid in my entire high school. And you go to the high schools now, and they pretty well mimic the national obesity rates. Now, part of that has to do with a lot of the changes that have occurred in our society, including our diets. We're eating very nutrient-poor foods that are very high in calories, high in fat, high in carbohydrates. We're eating a lot of refined processed foods. We're spending a lot of time in front of these screens, whether it's computers, iPads, smartphones, TVs. So we're much less active. We're eating much less nutrient-dense food. And so let's just see the progression. One of the things also in our foods that I would encourage you all to start reading labels and avoiding is high fructose corn syrup. This is about when high fructose corn syrup hit the market and replaced sugar in all the sodas that we drink. It's in ketchup and everything else, but our bodies can't process high fructose corn syrup, and it directly drives the production of triglycerides in our bloodstream and the storage of fat. So one of the biggest favors we can do for ourselves is rid our diets of high fructose corn syrup. But let's look and see what happens over 5-year increments. Changes pretty rapidly. By 2001, of course, we're already having to invent new colors down here in the South. And 2005, over a third of the country is almost 30% obese. A BMI of greater than or equal to 30 qualifies as obesity. 2010, and they didn't have one out yet for 2013, but it's not getting any better. Things actually have stabilized out a little over the last year, but again, we're at over a third of the country is obese, and that's greater than 30. So we still have this in here where is overweight, and over half the country is overweight. So it's that process is driving much of the disease that we see in this country. Okay, this is a list of things that we refer to as red flags for cardiovascular disease, specifically heart disease and stroke. And a lot of these things, a lot of us suffer, but we don't necessarily associate them with cardiovascular risk. The first conference that I went to that teaches this method of vascular prevention, the Bale-Dunine method, this was my wake-up call. It was one of the first slides they put up on the screen. I saw myself on this list 5 times. And it really scared me and made me realize I needed to do something different. At that time, of course, I was chronically sleep-deprived, chronically stressed, 30 pounds heavier than I am today. And that was my shakeup that something in my life needed to change. So how all these things relate, we don't know exactly. But one of the themes you'll kind of hear through the talk today is the theme of inflammation. Because we know that it's commonly known that inflammation drives a lot of gastrointestinal disease, allergies, cancer, and now we're gaining this understanding that inflammation is driving vascular disease. And we know it's also inflammation that's driving a lot of neurologic disease, whether it's inflammation, it's this concept of excessive oxidation leading to production of free radicals that damages the vascular system, that damages the nervous system, and causes disease like MS, Parkinson's, Alzheimer's disease. So anytime today that you hear inflammation, just think of that with respect to Parkinson's disease, Alzheimer's disease, vascular disease. But that's how a lot of these things like rheumatoid arthritis, psoriasis, those are all autoimmune inflammatory mediated diseases, celiac disease. And again, we don't know the exact link. It's just that in these conditions, we see a higher incidence of cardiovascular events, heart attack and stroke specifically. So this is, again, not an exhaustive list, but lists the risk factors that exist for developing dementia. Interestingly, you'll see a huge overlap between what you see on this list and what you saw on the risk for cardiovascular disease. And again, it's, well, almost all of them except for cognitive inactivity. Alcohol intoxication early in life damages the developing brain and increases our risk of dementia, head injury. But a lot of these things, and really the hope when you look at these lists, or this list in particular, a lot of these things are totally treatable and preventable, and there's a lot of our risks that we can eliminate and thereby reduce our risk of future disease. Let's see if I can get this to come up here. Whoops. Well, this is a video. It may not come up here. Well, we'll go on to the next. It's not popping up, but this is kind of a two-dimensional review of what that video was. So, and what I wanted to show was that where this process of vascular disease develops. We go from having normal healthy arteries in our 20s, and thankfully not all of us go down this route, but again, because vascular disease is the #1 killer, many of us go down this route of development of disease in our arteries. So it starts with a thickening in that arterial wall, and then it's inflammation on the surface of that artery that makes your artery more permeable and more liable to take on cholesterol. Even in a patient who has what we would typically tell them as normal cholesterol levels, they may be at risk of developing vascular disease if they've got inflammation of that arterial wall. It's just like opening the doors to your arteries and letting cholesterol come on in. And when that happens, of course, a series of things develop, but we ultimately develop plaque buildup in the artery. And if nothing is done, if it isn't diagnosed that that's going on, that process just advances until we get further and further plaque deposition. And ultimately, it's a different form of inflammation, but inflammation deep down within the wall of the artery that can, the way I refer to it is convert this mountain of plaque into a volcano of plaque. And if that plaque erupts, if that volcano erupts, what's going to happen is your body tries to heal over that defect in the artery wall by forming a clot. And if that clot gets big enough, of course, it blocks the flow of blood. And if that blockage is in a coronary artery surrounding the heart, we have a heart attack. If that's in a cerebral artery leading to the brain, we have a stroke. So the key is, how do we, ideally prevent this buildup at all? And if we already have that buildup, how do we prevent that buildup from erupting and causing a plaque rupture and a subsequent heart attack or stroke? And the answer is, in our current standard of care, we don't have a way of doing that. We don't have a way of assessing for that. But I'm here to tell you, science has evolved, and we have that capability now. It's just not being done by the vast majority of physicians because it's not yet most of us are driven by what's called the standard of care, and we do what the standard of care dictates. But testing for this is not yet the standard of care, and so most physicians don't know how to do it and aren't doing it. It's not that they don't care about their patients, it's just that it's not even taught in medical schools yet. Okay, so let's turn to the traditional methods of identifying when people are at risk. So EKG, treadmill stress test, and nuclear stress test, that's kind of considered the gold standard right now. If someone is having chest pain and we want to know if they're in trouble and they need an intervention, whether it's a bypass or a stent, we do a nuclear stress test. Or if we're more concerned about symptoms of stroke, we would do a carotid Doppler ultrasound. So interestingly, all these tests have one thing in common. Okay, they're all looking for restrictions in blood flow. Okay, well, so I guess the question is, what constitutes a restriction of blood flow? So if we go back here and look at a normal artery, you're not going to fail that test, any of those tests, until your artery is about 70% narrowed with plaque. Okay, so the scary thing is, the only people we're going to identify with those tests are those who are at the end stage of disease that need a bypass or a stent. But what about the rest of us that are sitting here with 20% narrowing, 50% narrowing, that may be at risk of a plaque rupture and a heart attack? But we go and have that test done and we're told, you're fine. So that's the really scary thing, is that the tests that we are relying on to identify those patients at risk are only catching the people who are at the end stage of disease. The rest of us may be at risk and suffer a heart attack or stroke tomorrow, even if we went for one of those tests and for evaluation. So we need to be looking at something different. We need to be looking not at who has end-stage disease because they're having symptoms of chest pain, but who has disease at all. Because if you've got any disease, you're at risk of a plaque rupture causing a heart attack or stroke if that plaque becomes inflamed. Okay? Okay. So that just kind of is review. So if we're going to prevent heart attacks, strokes, and dementia, we need to be looking at something very different than we're currently looking at. And we need to be looking at things decades before our current tests are able to identify those patients that are at highest risk. Okay, so there are a couple different tests that can be done. Rather than just looking at restriction of blood flow, is saying, well, let's just look at the health of the artery, because that's how we're going to know who's at risk. And this particular test is called a Carotid IMT, or intima media thickness ultrasound, is looking at the health of the arterial wall. Okay, and we can see in this patient, they've got perfect arteries. There's no evidence of disease buildup in that artery. However, we look at this patient, and they do have thickening of the artery wall here, and then here's a plaque sitting in there. So this is where it's black is where the blood is flowing. But if I sent this patient for a traditional test, whether it's a treadmill or a nuclear stress test, this patient would pass that test any day because there's no restriction of blood flow. And yet, if this plaque gets inflamed and ruptures, this patient could have a heart attack tomorrow. But I'd have otherwise have had no way of knowing. and they would have been told you're fine. Another test, just in case it comes up or someone wants to ask, another really good test for early diagnosis of disease is something called a coronary artery calcium scan. That's a CAT scan, specifically looking at calcified plaque within the coronary arteries, and that's also very specific, but it does involve radiation, so it's not something that I order as frequently in patients to get a baseline look at their arterial health, but there are certainly groups of physicians that use that more frequently than this ultrasound. Both are good screening exams, particularly those patients that are kind of in an intermediate risk and we don't know how aggressively to treat them. Okay, so let's, this will kind of be review here, but I just want to pause here because this is what we're missing in our current standard of care, is this concept of vascular inflammation. And it's without it, there's no way for us to be predicting who's at risk and when they're at risk. There's these two tests, which maybe a lot of you are familiar with, CRP, C-reactive protein. It's a fairly non-specific marker of inflammation in the blood. It can be elevated in anything from infection to cancer. And then microalbumin is a test that we measure for in the urine. But basically, both of these are more specific to inflammation on the surface of the artery. Okay, so when that inflammation is present, let's say someone's on 20 milligrams of Crestor, which is very high potency statin, and kind of considered the gold standard, even in the new American Heart Association guidelines, as aggressive treatment for someone. Well, let's say we've lowered their LDL cholesterol to 40, which would be a very aggressive goal, but they've got inflammation on the surface of their artery. If that inflammation persists, their arteries are still at risk. And so, though we often focus in traditional medicine on cholesterol levels, ultimately what we need to be treating to is not to a goal of a certain cholesterol, although that may be part of an appropriate treatment method, but is we need to be treating this inflammation. Because if we haven't extinguished inflammation, we haven't extinguished that patient's risk. And then there's these other two markers that are found in the blood that I really refer to as the seismometers of our vascular system. So just like a seismometer that tells you a volcano is going to rupture, if someone has high levels of these in their blood, it tells us they are at risk of a plaque rupture if they have vascular disease in their arteries. Okay, and that can be multifactorial. It's not as simple as just you find this, put them on this medicine. At least not to date. There is a company that's in stage 3 trials with a drug that's a direct inhibitor of this form of inflammation, but it's not available yet. But inflammation can come from many, many different sources. It can come from excessive stress in our lives, inadequate sleep, from multiple conditions, including sleep apnea. The statins are a very potent extinguisher of that form of vascular inflammation, but they may be inadequate in a lot of patients because we have well over a third of patients who suffer heart attacks are on the medications you would typically put them on if they had a heart attack. So the current medications aren't always enough to extinguish that inflammation and remove risk from people's lives. But my treatment methods really revolve around identifying these sources of inflammation and extinguishing that inflammation, and thereby being able to assure someone they can live their whole life free of cardiovascular disease. And one of the things I often say is, and die of something you can't prevent. But hopefully that's going to be very late in life because, of course, cardiovascular disease often robs us of our life in our earlier decades. So My goal, certainly in the future, is no one should ever die of a heart attack or stroke if they're equipped with this information and go through the process of evaluation and adequate treatment. Should be able to live long into late life healthy. So I know a lot of you probably can't read these. I just wanted to kind of give a brief overview of the type of laboratory evaluation that we do that's necessary to evaluate someone's risk. Up here is just the standard cholesterol analysis that every doctor's office in America does. But oftentimes that leaves a lot of cholesterol-related risk undiscovered and as such untreated. In fact, you can have, this is LDL cholesterol. You can have an optimal, which would be in the green, optimal LDL cholesterol and still have very high risk in what's called the advanced lipid analysis, because LDL often underestimates risk. So we look at advanced factors like what's called ApoB, LDL particle number, the LDL particle size. Those things can help to elicit additional risks that you wouldn't necessarily know just by checking your standard cholesterol panel. This section down here, can any of you read those? It's probably too blurry, isn't it? This is a section of checking people's inflammatory markers. And that's really, you can see in this patient, they had quite a high level of that, one of the seismometers of their arteries. So they were at high risk. So then the responsibility was on us to find out where's that coming from. These are specific markers of cardiac stress and strain on the heart. I'll kind of go through these quickly since no one can read them. We do additional factors. This is called apolipoprotein E, which is a genetic test. And that really guides us in how people might respond to certain medications, dietary things such as wine and fish oil and things like that. Because not everyone benefits from those things. Some people benefit from those more than others. And some people, in fact, alcohol can be detrimental to their cardiovascular risk. So that really helps to guide us in that. This whole panel up here is looking at one's risk for prediabetes. And that's just key. Again, my goal with my patients is no one should ever develop diabetes. If we're catching it early and giving you the lifestyle guidelines and what to do to prevent it, because most of type 2 diabetes is driven through obesity and then not exercising and eating foods that are rich in carbohydrates. So by controlling blood sugars, we can totally prevent diabetes. Vitamin D is another one that certainly we assess for, because deficiencies, which are really common in the northern latitudes, most people that we test are either low, what we call insufficient, or deficient in vitamin D. So most of us could benefit from a vitamin D supplementation. And then this one is homocysteine. And in fact, that's something I'll touch on in a little bit too. But homocysteine has been implicated in increased risk for dementia, cardiovascular disease, and now even Parkinson's disease. Homocysteine is an indirect marker of folic acid nutrition. And of course, you get folic acid from most of your raw vegetables. So that's an important one to identify. And then we do the standard chemistries. One of these up here is checking people's iron storage, and we'll touch on that and why that's important may be important for Parkinson's disease. This patient also had a elevation in their GGT, which is diagnostic of fatty liver disease, which typically goes hand in hand with obesity, with diabetes. Let's see what else. This is looking at blood counts, which is pretty standard, but again, looking for cardiovascular risk if there's deficiencies or too numerous or too many platelets or red blood cells, things like that. And then again, this is another one that's beneficial for both checking. It's called the omega-3 index. It's a fairly new test. It's basically looking at our the most beneficial omega-3s from a cardiovascular standpoint come from fish. You can get omega-3s from plant sources also, like flaxseed and things like that. But those haven't been shown to be as helpful from a cardiovascular benefit. In fact, with respect to dementia, in the Journal of Neurology last month, they published a paper that the study looked at over 1,000 postmenopausal women, and they measured both their omega-3 indexes as well as the volume of the hippocampus in the brain, which is that area in the brain responsible for memory retention and Alzheimer's disease. And they found that those women that were highest on their omega-3 indexes had the largest volumes in their hippocampus, equivalent to about a year or two more of memory, which for anyone that's taking care of anyone with dementia, a year or two of memory would be a gift greater than you could describe. So for a lot of us, omega-3 supplementation or regular consumption of fatty fishes can be beneficial from a cardiovascular standpoint, a cognitive standpoint, and a neurologic standpoint, potentially from a standpoint of Parkinson's disease. Okay. I wanted to, I guess, just kind of bring it down to a more applicable level and just look at some other things we can be doing to positively impact our cardiovascular risk. Again, because if we're impacting and benefiting our cardiovascular system, we're improving the health of our brain, we're improving the health of our neurologic system. Blood pressure is something that, in my opinion, is not nearly aggressively treated in our country. In fact, the newest recommendations, which are called the JNC8 recommendations, just came out, and they're still not recommending treating blood pressure until it's 140/90. There's many of us that don't agree with that and think we should be much more aggressive in treating blood pressure. You can see this study was based on 1 million healthy individuals, so it's not a small study. Starting with a blood pressure of 115/75, every rise in 20 on the top, or what they call the systolic blood pressure, and every rise in 10 above 75 on the diastolic blood pressure resulted in a doubling of lifetime cardiovascular risk. So those of us that have gone to our doctor and our blood pressure is 145/90, and we're told that's good enough. Well, that carries with it a threefold increased risk of cardiovascular mortality, death. So if I'm the patient, that's not aggressive enough. And that's, it's interesting when you look at diabetics who are at huge risk of cardiovascular disease. Studies have shown, typically we're treating those patients' blood pressure, blood sugar, and cholesterol. And typically we're trying to most aggressively treat their blood sugar. But studies show the way we impact positively their risk of cardiovascular events, heart attack and stroke, is by being more aggressive with blood pressure. So yes, we want to be aggressive in treating all those risk factors, but if we had to choose one, the one thing we should be aggressively managing is blood pressure. And so all of us should be shooting for keeping our blood pressure well below this. And my goal with my patients is getting as close to this as we can, but certainly keeping it below 130/80 most of the time. Certainly with diet, we can all stand to do, well, not all. There's some of you that are really good, but most of us can stand to make a lot of changes in our diet. And one of the things I say often to patients is prevention doesn't require perfection, it just requires intention. And, if we're just making little changes day by day, it's amazing a year later where we find ourselves. And in fact, one of the things I'll just share from my own life, which it shocks me even to say it, but 2 years ago, I used to drink 6 Diet Cokes a day. I mean, that Diet Coke was my water. So anytime I thought about sipping something, it was a Diet Coke. And now I drink water all day long. But it didn't happen overnight. I went down to 5 a day and 4 a day. And most of us need a gradual change. But this is a huge way that you can impact your health for your kidneys, for your cardiovascular system, and impact your blood sugars, your weight. So I really encourage people. Water is the best thing for us. We are made up of mostly water, and so it's best to replenish ourselves with water. God did not make us with high fructose corn syrup or aspartame or any of those things, so we don't need to be replenishing those. I encourage my patients to reduce sugar consumption to a minimum, and that includes, whether we eat it in the form of raw sugar or whether we're eating it in the form of rice, pasta. Most of us Americans love bread, crackers, things like that. But those, once they're in our system, they get converted to sugar, and then our body has to deal with that. So it's either driving vascular disease, driving neurologic damage, or driving fat accumulation. So the less refined carbohydrates we're eating, the better. And we do need carbohydrates. You can't survive on just protein. But the best way to get our carbohydrates is in the form of vegetables and fruits. Again, I encourage patients to focus on more vegetables than fruits. Fruits are good too, but they certainly have more sugar. One of the things people often ask about that is, well, how about juice? Well, juice is basically the sugar. If you were to, and I'm not a huge fan of juicing, although, what's his name, Jack? Yeah, so he's done pretty well with it. But most of us, what I'm more in favor of is having like whole smoothies. Because then you're getting the fiber and everything else that was originally in the fruit and vegetable. And because when we just have the juice, it spikes our blood sugar. But when you're eating the whole fruit, whether it's just or vegetable, or putting it in, pulverizing it into a smoothie, you're getting the fiber. And one of the benefits of fiber with the carbohydrate is you can see it reduces carbohydrate absorption, so it slows the uptake of the sugars, and thereby reducing insulin release. So anytime sugar goes in, our body's got to produce insulin, and high insulin levels lead to fat accumulation, and it's pro-inflammatory. Fiber also induces a sense of satiety. So when we're just juicing, you're not typically going to feel as full as if you're getting the fiber, and so you're typically going to consume less. And then the benefit of both fiber and protein is that they help to stabilize blood sugar. So again, it's one of the things I really encourage patients to do when we're typically when we're hungry, we're just grabbing for something quick, which is typically in the form of a carbohydrate. But just trying to be more intentional about pairing anything that we eat as a carbohydrate with some protein, whether that's lean meat, whether it's a dairy source like low-fat yogurt or cheese, or for those that are vegan, there's a lot of choices, whether it's nuts or legumes, things like that. So that's something I try to do every time I eat is balance and make sure I'm getting protein, fiber with my carbohydrates. Because any of you that have had chips or crackers or anything like that know that it satisfies you for about a half hour and then you're starving again. And that's because it converted to sugar and your body burned that up or stored it in about 30 minutes, and now you're hungry again. So that's the benefit of fiber and protein, is it carries you over. One of the things I changed in my diet was I dish out my whole family in the kitchen so that we're less likely to go for seconds. And I know in my past life that definitely contributed to my weight gain, going back to the kitchen 3 and 4 times. And then one of the biggest things, and again, I talk to patients a lot about this, is this one. And granted, there's some of us with Parkinson's are really limited in our ability to exercise. But all of us can do something, whether it's if we're sitting and just moving our arms or sitting and moving our legs. Activity is our most important, all of us, our most important prescription for long-term health. And I encourage all of you that haven't seen it to watch this YouTube video called 23.5 hours. You can just Google 23.5 hours and it comes up. And I'll just, again, share a story from my own family. I saw this video and it really started to make a change in my mind as far as looking at and prioritizing my day for exercise. Because in my previous job, I worked about 16 hours a day. I didn't exercise, and I felt terrible, like chronically fatigued and struggling to stay awake. And it takes anywhere from 2 to 4 weeks when you're starting to exercise for it to feel good, and then it starts to create in you a feeling like I don't want to go without that. But it does take a couple weeks. But if you stick to it, you'll start to really feel the benefits of that exercise. But anyway, one day I was encouraging my daughters, let's go to the store and we'll walk to the store and get some food for lunch. And at the time, my 10-year-old said, "Oh, Dad, it takes so long. I don't want to, let's just take the car." And so I said, "There's something I want you to watch." So I sat her and her youngest sister down in front of the computer, and they watched this. And at the end of it, it's about 8 or 9 minutes, she got up and she said, "Okay, let's go walk to the store." So it's even in the 10-year-old mind, she got it and understood how important exercise is. And you can see here, without any pills, decreases the incidence of progressing dementia by half, decreases the risk of prediabetes converting to diabetes by almost 60%. And the list goes on. Reducing your risk of death by 25%. Most of us are so willing to pop a pill, and many of those don't even come close to reducing our risk of death this much. So it's just huge, and there's nothing I could give you that could do all these things. And in fact, this one, it just amazes me. I don't know how they recruited these patients or found them, but they did a study and showed that patients who smoked yet were aerobically active, it just seems like an oxymoron, but those people exist out there, actually had a lower incidence of cardiovascular events than those who were sedentary but and didn't smoke. So what that showed us was that a sedentary life is a bigger risk factor for cardiovascular disease than smoking, which is just astounding because, of course, all the education that goes out there about stopping smoking and all the efforts and millions of dollars in organizations that spend countless hours trying to get the public to quit smoking. But thankfully, there are people like, the NFL that's now putting out ads about, encouraging kids to be active for 60 minutes a day. But it is. Our physical activity is the most important thing we can do to preserve our health. And with respect to Parkinson's disease, what we see clinically, and again, my practicing partners treat Parkinson's disease, so I'm kind of on the side of disease prevention. But certainly, what they will tell you, and what I even saw in my clinical practice as a family physician, was that those patients who have Parkinson's but stay physically active have much less disability. They deal with less stiffness, and over time, they maintain their activity level much, much better than those that are inactive. So again, it doesn't matter what you're dealing with, whether it's depression, anxiety, cardiovascular disease, diabetes, Alzheimer's, or Parkinson's disease, this is your most important prescription that any doctor could give you. these are just a few other things to mention for those that suffer from Parkinson's disease. And I'm sure none of this may be new information to you, but just reinforcing the importance of eating fresh raw vegetables and fruits, because that's where we're getting our folic acid. Of course, it'll help many other things as well, but and folic acid levels can be checked. We typically more indirectly check them through homocysteine levels, but you can also check a serum folic acid folate level. Sorry? Oh. We typically will first screen people with a homocysteine level, and then if that is low, then we're typically recommending supplements, and then when we do a follow-up, then we'll also check the B12 and folate levels. And this is one really that we should be talking to our children, our grandchildren about. It's something that certainly I wish, when I was doing my home remodeling, I would have been more conscious about my exposure to this stuff. So, we sometimes read those things on labels and think, yeah. But it is really, really important, because those things create oxidation in our systems. Oxidation leads to, again, free radicals, which can damage the vascular and nervous system. So these are really, really important. And again, you may even want to consider your practices in the summer about using some of these herbicides, things like Roundup, when it's windy outside, and that stuff blows up in your face and you're inhaling it. So just things to think about. Iron. We all need iron. It's very important. It's what carries oxygen in our blood, but high levels of iron can be damaging to the tissues in our body, and may be implicated in, can contribute to brain nerve cell death. And again, when we do our screening tests, that's one of the things we're testing for is serum ferritin, TIBC. Sometimes the iron levels aren't accurately reflective of what's going on. So these are more sensitive markers for if you have an abnormal storage of iron in your body. And the worst form of abnormal iron storage is known as hemochromatosis. And that's where iron gets deposited into our organs, causing liver failure, can damage the heart and other organs, and certainly damaging to the nervous system. Okay. We're getting near the end. I wanted to make a note on the importance of oral hygiene, not typically something you expect to hear from someone talking about cardiovascular disease, but this study should drive it home. Prior to me seeing this study, I'm kind of embarrassed to say I used to brush my teeth once a day, if I was lucky twice a day, but I was often running out the door and missing it in the morning without even eating breakfast. But what these statistics mean here is that if we use as a baseline people who brush their teeth twice a day, people that only brush once a day had a 40% increased risk of cardiovascular events. Okay, people that brush less than once a day, a 230% increased risk of cardiovascular events. So why is that? Well, that small intervention of brushing our teeth twice a day actually decreases the chance that we get this buildup of anaerobic bacteria that hide within our gums. That's why the dentists, when you go and get your cleaning, why they're calling out the pocket depths when they say 1, 2, 2, 1, 3, 4, 5. The deeper those pockets, the more likely you are to harbor these anaerobic bacteria. And cardiovascular studies have shown people that have high levels of those bacteria can have very high levels of vascular inflammation. And again, if you've got plaques in your arteries and then inflammation enters those arteries, now they're at risk of rupture. So one of the greatest ways you can reduce your risk is just simply brushing your teeth twice a day and flossing every day. I often tell people a Sonicare is the cheapest cardiovascular insurance policy you could buy. And it does do that much better at cleaning our teeth and increasing the oxygenation. Because if we get oxygen into those gums, it kills the bacteria. They're anaerobes, which means they function in non-oxygen environments. So if we give them oxygen, they die. So Sonicares are really a great investment. You can get 2 for $100 at Costco. Not paid by them, but they do have a good deal going there. Now this is overt periodontal disease, so that's inflamed gums, painful gums, bleeding gums with brushing or flossing. In this particular study, showed a almost 400% increased likelihood to have a heart attack. So 2 times more likely to have a stroke. So our oral care directly translates into our vascular care. How much time do I have? Should I wrap it up? Okay. Okay. So these are just quick review. So today, what cardiovascular prevention requires is a few simple steps. One is identifying what your risk factors are. And that's what we do through history, also through our advanced laboratory analysis, finding what are all those things that may be contributing to the development of plaque in your arteries. 2 is identifying whether or not you're truly at risk today, getting a baseline assessment of your arterial health, which can be done through either one of these tests. And actually, even if one wanted to pay cash, this test is $200 to $300. This test is $300. Occasionally, once a year, inland imaging provides it at $100. So honestly, one of the best investments you could make in your health and kind of knowing where do I stand, rather than just hoping or assuming you're not at risk, you can know if you're at risk for $300. And sometimes insurances will pay for that one. And then what we have to do is assess for vascular inflammation. It's the only way we know. It's the hallmark of disease activity. It's the only way we can tell people when they're at risk and be able to guide them away from that risk so that they never have to suffer a heart attack or stroke. And it's really what guides all of our treatment algorithms. And then once those things are done, then we can develop a comprehensive treatment plan to extinguish any inflammation, to minimize the risks that have been identified, and allow you to live a healthy, long life free of cardiovascular events. So bottom line is heart attacks, strokes, diabetes are absolutely preventable in 99% of cases. Dementia, we can significantly reduce the risk. And again, estimates are with more aggressive cardiovascular care, we can reduce risk of dementia by 1/2 to 2/3. And certainly our hope, science is yet to prove, but because the vascular system feeds the nervous system, we certainly hope that with more aggressive care of our vascular system, we're also going to have a tremendous impact on future incidence of Parkinson's disease. And prevention isn't just a convenient or nice concept anymore. It truly is, in cardiovascular medicine, it truly is a reality. And all you have to do is start taking proactive steps to get involved, to get yourself assessed, and then just start making small choices, even if it's just, I'm going to walk out to the mailbox twice today instead of once, or I'm going to take the stairs, I'm going to park further away from the store. Starting with small things like that, trying to eat more fruits and vegetables, less refined carbohydrates. Little things go a long way in our health. And of course, the encouraging thing is what you do is learned, whether it's your children, your grandchildren, your friends. It's really infectious. And as we make more positive choices and people see the changes in us, people start asking and saying, what is it that you're doing? And we can have a huge impact in the lives of those around us. So thank you very much for your time. This also is a book that was recently published by the founders of the treatment method that I use, and is a great resource for anyone interested in that.
Okay, don't go away. We're gonna visit I have down 10 sites that checked in. If I miss you as I'm going down the list, chime in at the end and tell me that you're there. Same as usual. We'll have you give the number of people at your location, and let us know if you have any questions that Dr. Emery can answer. I'm going to do 1 little minute. I don't normally do this, but I've actually done the program that Dr. Emery does when we found out about it, because I believe preventive medicine is really important. I don't have any background in my family for heart disease, stroke, and things, but I am overweight and have some other issues, and so I went and did it, and then my husband went and did it. And what I found out is that I have on that test, there's those red squares, I have a marker where I have a 4-4, and if you do the program with him, you find out what that is, but it's a genetic marker that says I have a really high risk for vascular inflammation. So we went, oh, well, let's go look at my veins. And we did the carotid artery test, and I have little or no buildup in my veins. So what was good about that is I found out now I don't have that, but it's completely changed the way I eat. I was already eating much better because of other problems, but I've reduced the amount of red meat by 3/4. I used to eat it, I would say, 10 times a week, and now I eat, 2 times a week. There's a lot of changes that I'm making. So it's a really, really good program. And then my husband on the other side of that has really high cholesterol, and you don't know his name, so I'm not giving away any medical information, but really high cholesterol, really high lipids. And he was the one that I actually wanted to get into the program, because with those numbers, you wonder about what's going on, and we had him in, and he's actually doing pretty well. He can, what is his level of buildup in his arteries, he can do with food changes and later on statins if he needs to. So it's a really good program. And I wanted to say, you just started taking Medicare and Medicaid, is that right?
We'll be taking Medicare by April 1st.
By April 1st. And so generally this isn't a ad for our speakers, but I really want to say preventative medicine isn't considered as important as it should be, and I think it should be the start of all of our medical field. So Dr. Emery's office is a really good office to go. It's a really good thing to try. So anyways, there's my 2-minute commercial for Dr. Emery. Thanks. And if you have questions about it, I'd even let you see my paperwork on how everything turned out so you could see my numbers. Let's see. Anchorage, Alaska. Are you there today? Billings, Montana. Clarkston Tri-State Memorial.
Yeah, hi, Cindy. We enjoyed the presentation. Just a little bit long, but we appreciate all the information. We have 18 here, and we did have one question, Dr. Emery. You mentioned free radicals being something you would want to get rid of. Do you have any recommendations regarding vitamin C?
Not specifically. I don't discourage people from taking it, but I don't know of any test or any study that gives us a real clear guidance on the optimal level of vitamin C. So I'm not a big fan of mega doses, but certainly if people are taking anywhere between 1,000 and 5,000 milligrams a day, that's probably adequate. So, and then of course the other thing I just encourage people, we can reduce free radicals through our lifestyle, through exercise, through eating plenty of raw fruits and vegetables. So I think it's always better to get it naturally, but again, that's not always possible. And so I think a certain amount of supplementation with vitamin C is not a bad idea.
Thank you very much.
Thank you, John. Thank you, everybody. Okay, Coeur d'Alene, Kootenai Medical Center.
We had 16 here today, and we have one question.
Thank you.
Question.
Okay.
What was the name of the movie that you show on YouTube?
23.
Oh,
The name of
about the exercise?
Yes.
23.5 hours.
Okay, thank you.
You bet.
The other question I have is, you mentioned the vascular effect on dementia. Is there any studies, or do you have any information on keeping the brain active with puzzles and Sudoku?
Yes. Yes. In fact, that's very important. Dementia prevention. In fact, one of the reasons why a lot of us recently started seeing Lumosity.com advertised on TV and radio was that they've just recently published some studies to show that regular use of that can actually stimulate areas in the brain that weren't previously showing levels of activity on brain scan. So we know the brain is much like, even though it's not a muscle, it acts like a muscle, and when we don't use it, it atrophies and we tend to lose it. So we know that it's very important as we age, and particularly when we get into retirement years and we're not necessarily engaged at work and in these demands that really force our brain to be working. We're doing hobbies and things that are just enjoyable, but that's not really working our brain. So yes, doing I never know how to say it. Sudoku.
No, Sudoku. Yeah. Starts with an S, and it's really kind of
brain games. And in fact, even reading, even though that's good, that's not typically challenging enough. So I really highly recommend Lumosity. For those that are a little type A like myself, I just have to warn you, you're not supposed to master it. It gets harder and harder the better you get, and that's the whole point, is that it should continue to provide a challenge. Once it's no longer a challenge, it's not helping your memory anymore. So. And it's less than $100 a year, I think. So.
Is that what it is? Well, in Luminosity, and then now the trend seems to be the video games that are for little kids, or used to be for little kids or teenagers, whoever. Now the Game Boys and those, they actually have brain games that you can get with those, that you can carry with you everywhere. But fun, yeah. I didn't know Luminosity was $100. Mm-hmm. And the video, when I typed in 23.5 hours, came right up. It was the first thing that came up, so it should be pretty easy to find. Colfax. Colville.
We have 3 today, and no questions other than a comment that one way to increase your vitamin C is eat lots of oranges and mandarins. It helps immensely.
And it tastes really good.
Yes.
Thank you for joining us today in Colville. Jump down to Moses Lake, Samaritan Healthcare, please.
We have 9 here today. Excellent program. Thank you very much. And it really wasn't too long. I think we could keep talking. We do have one question.
Okay.
He has one here.
You mentioned sleep deprivation was damaging. I slept fine until I started taking Parkinson medication. So what are you supposed to do about this?
That is a challenge. I guess what I would encourage you to do is talk to your medical provider about that, whether medicines need to be adjusted, doses, times, things like that. And because yes, sleep is absolutely essential. We know in people that sleep is when our body is undergoing all its reparative processes. So it's not realistic to expect that we're going to function well and age well when we're not sleeping. In fact, we know patients that sleep less than 6 hours a day are much, much more likely to develop diabetes, obesity, deal with stress, anxiety, depression. So yeah, I guess I wish I had just a simple answer, but there may be techniques they want to discuss with you, supplements like melatonin, ideally not adding more things, but maybe adjusting or changing the way things are being prescribed so that it isn't adversely affecting your sleep. But
do you have any information on the hours of sleep? I mean, I sleep well for a couple hours and I'll wake up and I'll go back to sleep, and I can sleep during the day. I can sleep probably anytime, but it's not long periods of time.
Well, yeah, that's a good question. My question to patients is always, if you add it all together, how many hours of sleep are you getting a day? And again, my goal is a minimum of 6 hours. So, if you can piecemeal it together and you're getting at least 6 hours, that's still beneficial. A lot of people do deal with difficulty falling asleep or difficulty staying asleep. And there's different things that can be done depending on what the problem is, when the problem is. So it's very possible that your medicine's wearing off, and when that happens, then you're waking up. So that's something that maybe your prescribing physician could help adjust.
Thank you.
Thank you, Moses Lake, for everybody for attending today. Port Townsend Jefferson Healthcare. Pullman Regional Hospital.
There's only one person here today, and I have at least one question. There's been a recent announcement of a new blood test for Alzheimer's. I don't know if that will also show changes that predict the presence of Parkinson's dementia. Do you know anything about that? And are any tests being run locally on the use of this medication that one could join?
Oh, are there any studies being done? Was that what you're asking?
Locally. Are
Locally.
you locally doing any tests so that someone could try and find out whether they were at risk for Parkinsonian dementia or for Alzheimer's?
I don't know. I wish I could comment on that. I don't know about that new test yet. I'm sure my practicing partner, Dr. Greeley, does, because he's the one that's actively managing patients with Alzheimer's. But we could get your name and number, and I could find out for you, and we could get back to you.
Shall I tell Cindy? She knows me. I can call her.
Yeah, call me.
Diane at Pullman.
Okay. Yeah. Call me and leave me a message, or email me, depending on how comfortable you are with that, and I'll get your information to Dr. Emery. I just read that you're on the ball, because I just read that article, I think yesterday, about the blood test, and so hopefully good things. And you're even though you're just one, you are never alone. So thank you very much for being there today.
Thank you.
Tonasket North Valley Hospital.
Hello, there's 3 of us today, and we didn't have any questions. Thanks for the presentation.
Thank you for joining us in Tonasket. And then the last one I have, it says Forks. And I'm not sure, that's a new one to me. So if there's anybody out there that I've missed. I know we're Forks, because I read.
Yes.
Hello.
This is Miles City, Montana.
Miles City, thank you for coming on. How many people today?
We had 9 people today altogether, and thank you for your presentation.
Thank you for checking.
45 beautiful degrees.
How many? 45?
45 beautiful degrees and raining.
Well, the rain is supposed to be
good.
going away. Thank you for
Thanks
checking.
much.
Did I miss anybody else?
This is Billings, Montana.
Hi, Billings.
We had 3, 2 just stepped out of the room. The only question that I could think of, it was mentioned that dementia is a leading cause of death. How can dementia cause death? Because I forget where I put my book that's going to kill me?
Forget the
Yeah, because dementia is a progressive condition, leading to progressive decline in disability. That's, I guess, ultimately it's always, anytime someone dies, it's ultimately due to cardiorespiratory failure. But primarily, when they're looking at the statistics on that, it's what has led to that. In those cases, is the only identifiable thing that's led to the progressive decline is Alzheimer's or other forms of dementia.
Okay.
Thank
Do we
you.
have any questions from Spokane? Okay. One.
Thank you. Really enjoyed the presentation. The question I have is, how often do we need to repeat the carotid ultrasound?
That's a good answer, or good question rather. And all I can tell you is what my practice is. There isn't a clinical practice guideline that tells physicians and patients how frequently to do that. So it depends. In someone who has that I would consider high risk, that has significant vascular disease, the first year, then typically those patients, I'm following them yearly with the ultrasound to ensure that that the treatment that we have recommended is actually stabilizing disease and preventing progression. But in someone, for instance, like in Cindy's case, where she's got beautiful, pristine arteries at the outset, it wouldn't be warranted to check her earlier than maybe another, depends on all the other risk factors, but anywhere from 2 to 5 years. So it depends what the initial screening identifies, how frequently I would recheck.
And the second question is, what are the pre-diabetic glucose levels? You said, the standard glucose levels and the pre-diabetic glucose levels are different.
So typically what we would say is anything over 100. So I'll talk about fasting blood sugar and then also the hemoglobin A1C, which provides a 3-month average of the blood sugar. So according to the American Diabetic Association, sometimes I'm even a little more aggressive than they, but anything over 100 or over is considered in the pre-diabetic range. And then anything 125 and above is diagnostic of diabetes. Whereas in the hemoglobin A1C, anything 5.7 or over 5.7 is up to and not including 6.5 is pre-diabetes. And then at 6.5 and above, that's diabetes. So, and again, one of the things that I tell people, sometimes we rely too much on these numbers, because you can have someone who has, if all you're checking is a hemoglobin A1C, they could have a hemoglobin A1C of 6. But the only thing they're really struggling with is their what we call postprandial, or after they eat, blood sugars. So their fasting blood sugars may be perfectly normal, not likely, but could be. And if they were just eating a lot of carbohydrate-dense meals and their body isn't able to deal with that load, they could be having very high blood sugars, but when it's averaged out with the normal fasting, it makes their 3-month average still look acceptable, but actually they're a diabetic. So.
And you had a marker, MMPO or something for the inflammation? MMPO, what does that
MPO stands for myeloperoxidase. So it is different in routinely from any of the labs around. You could order a myeloperoxidase antibody. However, that's a thyroid test. Myeloperoxidase is a test that was discovered by Cleveland Heart Labs. And so you can only get it through them. We send our labs to Health Diagnostics Laboratory, and then they pass a blood sample through to Cleveland so we can get the myeloperoxidase level. Mm-hmm.
Did you have a question, Pam? Okay.
LPPLA2 that's the other seismometer, and more commonly recognized and understood. But again, insurances don't typically pay for it. If you get that done at PAML, it costs you $200. So that's one of the reasons we use HDL Diagnostics. They accept what insurance, including Medicare and Medicaid, gives them, and they don't balance bill the patient, which really is phenomenal. And people often ask, well, how does that work? I don't know exactly, to be honest. There must be, because I don't know the tax laws, but they must get a massive tax write-off at the end of the year, which probably leaves them very little reportable income. So it benefits them, it benefits our patients. So it's really great. Patients they don't pay anything for our labs, which is phenomenal, because it's typically about a $3,000 laboratory workup that patients get for free.
Ours, I think mine was $2,400, what it would have been if I had to pay out of pocket. Yeah. So
it's really a tremendous evaluation that people can get.
I think I missed the most important part about sleep. But I was glad to hear that the cumulative effect is operative. The first thing I did was try to make sure I was in bed long enough to count an hour or two. Mm-hmm. And then, and then go to bed early enough.
Yeah. Well, and one of the other things that I should have mentioned when that other person asked the question was, which often goes undiagnosed, is sleep apnea. So if one is sleeping 6 hours a day, and yet they're still struggling to stay awake during the day, the possibility exists that there may be some sleep disorder that isn't allowing you to ever actually enter into rest. Even though your eyes are closed and you're not conscious, you may not actually be sleeping or resting. And sleep apnea drives a lot of disease in this country, and drives a lot of vascular inflammation. So that's important. If you're sleeping but not feeling rested, something's wrong. So
I'm going to try to speak out so that you can understand what I'm trying to say.
Okay.
I've got Parkinson's, and my voice, of course, suffers from that. But one question I had is that you were dwelling quite a lot on sugar.
Mm-hmm.
You didn't say anything about salt.
You're right.
And I stay at a retirement home, Touchmark,
mm-hmm.
and the food is very bland.
Okay.
And I find myself using a lot of salt. What is that? How does that enter into it?
Well, and there's been a lot of debate about salt and and how important it is from a cardiovascular standpoint. And we think salt is probably most important early in life, particularly in childhood, adolescence, and early adulthood. There's probably less adults that are sensitive to salt than we once thought. And one of the biggest, the signs to look for if one is salt sensitive is monitoring the blood pressure. So because it could potentially be a source of hypertension or high blood pressure. One of the other big things is water retention. And so if one's using a lot of salt and they're having a lot of water retention, then the salt probably isn't the best thing for you. So it's probably better to use salt. Well, I won't say salt substitutes. Other things with like Mrs. Dash or something that has other flavors in it. But I tend to try to stay away from alternatives that are just other chemicals.
Thank you. My second question dealt with what you just talked about, but you showed graphs of blood pressure.
Mm-hmm.
And I don't know what your experience is, but every time I go to a new doctor, I go in a new day, my blood pressure is something else.
Mm.
So how do they come up with these numbers? How do you judge whether I'm 120 over 80 or whatever
mm-hmm.
because of the deviation in the tests?
Yeah. When I'm getting erratic blood pressures that don't seem to jive with what the patient is typically reporting, I encourage home monitoring, where you're doing it a couple times a day on a frequent basis. And then if basically when we should treat is if a third or more of those blood pressures are high, then it's probably too high and having a negative impact. So
the third thing is that it's just a commercial for Speak Out program of Eastern Washington University.
You're doing great.
I would strongly encourage
I can hear you perfect.
The Parkinson people in here to look at that program. It's excellent, absolutely excellent.
Thank you, because that leads me to my announcement that I was going to make. You had one more question? Okay, after this question, I'll make the announcement about the Speak Out. Here you go.
Okay, talking about blood pressure. Last couple of visits to the doctor, they're taking blood pressure on both arms.
Mm-hmm.
Any comment on that?
Yeah, and that's comes as a result of a recent study that we really should probably. Well, the reason is that it can vary quite a bit, and if it does, it shouldn't differ any more than about 20/10. And so if there's a significant difference side to side, that can be a signal that something's going on, whether it's a blockage in the artery to the side where it's higher. So yeah, it can be an important diagnostic factor.
And now we know why they do it. Yeah. So as the second part of that commercial, if you haven't already heard, thank you, Dr. Emery, by the way, let me do that. Thank you very much. And normally we have Parky the penguin, but I forgot my Parky, and so Dr. Emery's going to get 3 because he's got 3 kids, and you can't just have one. and well, you're never alone if you have a Parky, so I guess I could just do one. But Speak Out Eastern Washington is a voice program developed by the Parkinson's Voice Project, or in conjunction with it. It's a program that's 12 individual treatment sessions over 4 weeks by speech language pathologists. And I'm going to send this flyer out to all of the locations, whether they're checked in or not. But it's not just for Spokane. One thing that's about this program is they can actually go to outlying areas, rural areas. So if you live in Ferry, Spokane, Lincoln, Stevens, Whitman, Pend Oreille, and Adams County, this program could be available to you. And what they do is they'll come out to your home, possibly the first time, and then they can Skype, or they'll figure out a way to do it. And so I'm going to send this flyer out. I have copies of the flyers at the Resource Center. It's on the website, and if it might need updated for that. But it's a really great program, and there's several people here who will speak to that. And they'll speak loud. So,
and with intent.
With intent. And I can't think of anything else. Next month will be Dr. Jill, and I always say her name wrong, so I'm going to spell it Gjerde. She's a psychologist, and she'll be talking about caring for the caregiver and stress and Parkinson's. And we're really looking forward to having her with us also. Thank you for joining us.